All right. Thank you all for being here. My name is Bettina Hoeppner, and on behalf of our steering committees members here, I'd like to welcome you all. Today, we're going to do things a little bit different. We are going to try to limit our talking, and our goal today is really to hear from you all, because we get to assemble here a group of committed people, experts from different perspectives, and we really want to use this time and this opportunity for us all to hear from each other. So if you can go to the next slide, Catherine. Here is our ambitious schedule for today. We're going to do the live feature as usual because it's important that we ground ourselves in what we're talking about, and that's recovery community centers. And our goal is to advance the science on recovery community centers and to talk about how we can improve the evidence base that we have for it. So that's why we want to still take time for our live feature. We're going to follow that up with our usual poll to just kind of get a feel for who's in the room, from what perspectives you're coming to this topic of recovery community centers. And then it's going to get a little bit fast, and I will try not to speak too fast as I have a habit of doing. But at that point, I'm going to give you guys a 5-minute reminder of the data that we shared in our September and October seminars. This is about the nationwide survey of recovery community centers that we did. And I'm just going to remind you of some of the highlights from that. And then we're going to show you some of the topics that we came up with, the things that we were pondering and thinking about as we were reviewing the data. And that's where we then want to hear from all of you. So after I give you a reminder of the things you have seen, we will then bring you all into breakout rooms. And in those breakout rooms, we ask you to look over the questions we have, pick a question and discuss and share your thoughts and perspectives and ideas and everything else. After you've all done that for 15 minutes, we're going to bring you back into this main room, and then we're going to have a discussion in this main room based on what you guys all discussed in your small rooms. So pretty ambitious, but we're very excited for it. So let's get going. Next slide, please. All right, as promised, we're going to start with our live feature. Dr. Alex Elswick is here today to tell us about Voices of Hope. Alex?
Thank you very much for having me. I'm Dr. Alex Elswick. I'm an assistant professor at the University of Kentucky, and I'm a co-founder and a current board member of Voices of Hope, which is a recovery community center in central Kentucky and Lexington, Kentucky. And I've got just 4 minutes and I'm timing myself, so I'm going to move quickly. The first thing that you would notice if you walked into our center in Lexington that I think is distinctive is there's not as much discussion about drugs and alcohol, certainly not as much discussion about abstinence. And that's not because we don't support abstinence, but because we recognize that our entire treatment infrastructure in our community is dedicated to abstinence, and there's very little support for other pathways. So we traveled to the Northeast to CCAR in Connecticut and Anchor in Rhode Island to learn from those RCCs, and it was really beneficial to see that there are different models and that it can be implemented in different ways on the ground. And we came back to Lexington and began programming sort of traditional RCC programming, so things like telephone recovery support, on-site recovery coaching, hosting lots of different mutual aid meetings to support various pathways of recovery. But as we began doing that work, we started to notice that really that the infrastructure was supporting abstinence and abstinence alone, and just nothing more than a wink and a nod to medications for opioid use disorder and also for people who use drugs, because we recognize that everybody who's in recovery today was once a person who used drugs, and that's a really fertile ground for outreach. So with regard to medications for opioid use disorder, we developed an anti-stigma campaign because we recognize that all the time when we look to lift up examples of people in recovery, we make the mistake of only lifting up examples of people in abstinence-based recovery and sort of neglecting other pathways. So we started by lifting up real examples of people with lived experience with medications of opioid use disorder. We started a transportation program where our drivers, who are recovery coaches, will drive people to methadone providers so that they can get access to that medication that's so tightly controlled. We also have a barrier relief fund that might help someone to initiate or retain on medication for opioid use disorder, or maybe help fix their vehicle so that they can drive themselves, something like that. So a real explicit focus on initiation and retention of MOUD. And then with regard to people who use drugs, we've done a number of things, also an anti-stigma campaign and an outreach campaign. And we asked our community advisory board What do we need to say to get people who use drugs to understand that a recovery center is for them, that it's not just a place for people who are abstinent? And they said, just say that. So our our marketing materials said something like actively using ? You belong here, right? We also have a mobile unit which dispatches to locations where people who use drugs will frequent. And we were concerned about the viability of the van. And I'll tell you that the very first day that the mobile unit was on the ground, we reversed an overdose with naloxone, which makes it pretty meaningful, I think. On our mobile unit, we distribute things like harm reduction supplies. We're by law not allowed to distribute syringes. So we distribute safer using kits, fentanyl testing strips, things to that effect. We also distribute supplies more related to basic needs because we recognize that sort of universal recovery capital, food and water and blankets. And then the last thing I'll mention that I think is just cool and unique is one of my colleagues at the University of Kentucky came to us, and her name's Dr. Hartley Feld. She said, I think reproductive health access is a part of recovery capital. And we said, of course it is. And so she developed these things called, I think they're called pregnancy empowerment kits for people who can become pregnant. And they contain things like prenatal vitamins and a little bit of information. And it's just a way to provide sort of non-traditional recovery capital to the people who need it most. So that's Voices of Hope. And thank you all for this opportunity. I appreciate it.
Awesome. Thank you so much, Alex. That was great. All right. And with that, if you can move us to the next slide, Catherine. So as I mentioned, for our seminars, we bring together folks from all kinds of perspectives: healthcare decision makers, prescribers, clinicians, scientists, RCCs leaders and staff, peer support workers and volunteers, RCC participants, recovery advocates, and additional folks who are interested in caring about this topic. I want to do, I think the poll is next, Catherine, right? It's prepped. If you guys can just, as always, indicate which group you're from, because we always update our pie chart after every meeting to just kind of make sure that we're still staying in conversation with folks. So if you can just indicate here. Oh, wait, this is it shows the result, Catherine. It doesn't give me the chance to answer.
Because you're co-host, we won't be able to.
Oh, because yeah. Okay. So for the rest of you all, you can actually answer this. Apologies for that. If you can just go and click the answers, and then the little gray bar at the bottom, the side, if you can drag it down and complete. Oh yeah, now I see the numbers even moving. That's exciting. And I'll just give this a minute. I actually just closed this window, so now I can't see how we're doing.
We're at 60% so far.
All right, let's get to about 80% if we could.
Not letting me submit it. Oh, wait, never mind. I didn't answer all of them.
I know, I wish there was an option where you could skip. That would just make more sense.
I also want to mention that if anyone needs closed captions, we do have a captioner here today, and you can click it from the options at the bottom of your screen to turn them on.
Perfect. Thank you for that reminder, Catherine. How are we doing? Are we at 80% yet?
We just hit 82%.
Beautiful. If you want to close that up. Thank you all. So here you can see who our multiple stakeholder groups are and how they're represented here today, which is great. And we will ask you this question again when you are in your breakout session, so you kind of know who's with you, in case that helps you kind of like share your perspective and how much detail to go into and so forth. Great. So let me move us right along as time is fleeting. Here we go. All right. So as I promised, I was going to give you all a short, and I'll see that I actually make it a short summary of what we have done in the September and October seminar. As you all know, over the past year, our goal was to conduct a nationwide survey of RCCs. And we really tried to identify all RCCs to send an invitation to them to invite them to complete a survey. We think we did a pretty good job in identifying most. There's probably some RCCs that we didn't know about that we therefore didn't reach out to. So we're always continuing to complete this list. So please keep sending us more information for more RCCs so we can update this list as we go. Of the RCCs that we identified, 60 of them completed the survey. And the survey really served two purposes. We asked to get a description of the RCC, to just kind of understand what kind of services are being offered, how do they operate, what's their stance on certain issues, and that sort of thing. Alex mentioned going up to CCAR and Anchor to get a feeling for what the traditional RCC programming was there, and then how they wanted to adapt it back home. And we really want to understand what's happening a lot and versus of what's only happening in some RCC, and what else didn't we even know about. So description of RCCs was one topic. In the next half of the survey, we then asked RCC directors about feedback about how to measure the impact of RCCs. And we provided folks with some measures that we thought could be useful to document the impact of RCCs. And we asked directors to tell us what they thought about them. Are they good, bad, what's missing, what should be improved? And we shared that with you. If you go to the next slide, Catherine. Great. So our takeaways from the first part in terms of describing the RCCs, what we saw is that, yes, each RCC is unique, as we know from our live features. Everybody has their own, every has its own special feeling. But when you look across them, they're more alike than different from each other. So if you had somebody in recovery and you wanted to give them a referral to an RCC, you could rest relatively comfortable in knowing where you're sending them to, but you had an idea of what the model looks like. We also found that RCCs are welcoming, recovery-oriented environments for person using medications to support their recovery. And that's not always the case outside of formal treatment settings. So that's a really important finding for us as well that we wanted to know more about. We also saw that RCCs were remarkable in their proaction and really achieved successes in inclusivity regarding BIPOC populations in terms of the attitudes of medications, younger people, and so forth. And if you go to the next slide, I can show some of the data that supported these kinds of conclusion. So actually go to the next one first. We should have switched them, but that's okay. So go to the next one, Catherine. Here we go. I'll go back to that one in a moment. So in terms of demographics, for example, we asked the directors to report who comes through, who is, what are the demographics of people in their RCC who come through, and that kind of gave us a percentage in saying about 50% of our participants are male versus female versus then other, and then we averaged that across sites. And there we were able to see that in that 18 to 24-year-old bracket, about 20% of participants at RCCs were believed to be in that age bracket, which is pretty remarkable because usually it's very difficult to engage young people in certainly in formal treatment, but also in other recovery-oriented activities. So that's really impressive. When we look at race, we see here that 22% of RCC members were Black or African American. And again, that's impressive. That shows some outreach efforts. So, and then, we looked at ARCO RCCs versus not RCCs because we know a lot about ARCO members, about what the RCCs look like. They're following certain guidelines. Other RCCs may or may not do that. And by and large, we didn't find many differences there, really showing us that this model, this RCC model, is pretty consistent across different centers. Now, Kevin, if you go back to the previous slide for me. We asked people about how are they connected to other places around them. And these are the centers we asked about. We asked about connections to medical centers, substance use disorder clinics, prescribers, behavioral treatment groups, emergency department, churches, sober homes, justice system, and so forth. And we asked them, are they connected? And that's not the slide I'm showing you, which was about 80% of all RCCs were connected to any one of these types of entities. We then also asked them, do you wish that your RCC had more and or a better linkage to any of the following? And so they might have an existing connection, but the question was really, would you wish there was even more developed, working in a different way? And here you can see that a third of all RCCs wished connections were better. And the highest percentages you see here for medical centers, for example, 34 of RCC directors said that they wish they had a better connection to the medical centers near them. 37% talked about wanting a better connection to prescribers specifically for medications for substance use disorder. We have 34% of RCC directors saying that they wish had a better connection to emergency departments. So that got our attention, and we were wondering, well, given that there's a lot of wish for that, how do we do that? And that's going to be our question to you in the breakout session. Next slide, please. Actually, 2 slides at this point. Here we go. So that was part 1 of a survey. In part 2 of a survey, I had mentioned that we talked about different ways to measure the impact of RCCs. And we had suggested a number of scales. And I believe we have been seeing links in the chat about the actual slides for that, if I recall correctly. Basically, the good news was that the kind of scales that we had suggested were generally very well appreciated, or not appreciated, but they seemed to hit the right point. They seemed to connect well, which was good. There was also, however, a lot of feedback that we heard and that made us wonder more, and we wanted to connect to you all to learn more and to think through that. So one of the comments that we heard several times, which is important, is that an RCC's effectiveness can't just be reduced to individual impacts on specific people. RCCs does more. RCCs also impact the community in which they exist in terms of changing the stigma around RCCs, about opening people's hearts and mind, about doing a lot more than having impact on individuals. Then also some of our scales were about service delivery. And again, an RCC isn't just a service delivery place. It's also a social place. It's a place that people gather. It's a community. And that's not really adequately captured in the forms that we suggested. And then, mundanely, I'm a scientist. We have funding for pilot study funding. We want people to engage in more research on recovery community centers. The goal is to build up evidence to show that RCCs work and how they work and who they might work the best for and where new things are that need to be developed. And then when we asked about this, we got feedback of, well, if you're going to give people questionnaires for research studies, the second they walk through the door, that's very off-putting. And it's also very much alike to when you walk into a doctor's office and you first have to fill in your forms there for half an hour before you actually get to speak to a person. That's not what the RCC model is about. So that doesn't really work well. So the challenge for us is to figure out, well, how can we do both? How can we actually conduct good science and collect good data here without getting in the way of what's happening at RCCs? Again, that's going to be our question to you guys in a moment. Next slide. So what we have done is we have a PDF here. The link is on the slide, and I believe you've dropped it into the chat a couple of times. We have identified sort of a couple of topic areas that I just mentioned to you all that we wanted to get your feedback on. And what we're going to do next is we're going to put you into breakout sessions. So if you go to the next slide, actually, here we go. We're going to put you all into 6 rooms. We're about 70 people. So we're having about 11 or so people in each room. And you're going to be either in a room with me or with Acusia or Joe or Catherine or Deodora. And then Lily and Lindsay are going to share a room together. And we're going to ask you to introduce yourself to the group so everybody knows who you are. Then we're going to screen share the list of questions. We also ask you to download it so you have it in front of you when you want to refer to it. And then we're going to ask you to pick a question on that list or pick a completely different question that we should have been asking and didn't ask, and then discuss it as a group. Share your thoughts, what it made you think of, some ideas you have about it, anywhere that conversation is going to go. Then after about 10 minutes, we're going to get a warning that there's only 5 minutes left. At that point, we'd ask you all to pick a spokesperson who can share some of the insights or some of the topics that you all discussed in your breakout sessions to bring those back to the main room. And then after those 5 minutes are up, everybody comes back into this main room right here. And here we put on there, actually Catherine put on here very nicely for us, careful to either not click anything at all. This can just automatically happen. So if you don't have anything at all, you'll end up in the correct spot. If you do want to click it, click the leave breakout room. Don't click the leave meeting button. The leave breakout room button will get you back to this room. And then we're gonna, in this room, discuss what you all discussed in the small groups. All right. I think without further ado, do we need to hit the stop record button and then start recording when we come back?
Yeah, I can pause recording now.
Again. Perfect. Thank you, Catherine. How about you guys? It was way too short in our room. Did anybody else? Yes. Yes. So we just have to be good about continuing conversations in this big room now. What we're going to do to just kind of orient us to pick which room we're going to go to or what topic. Catherine, can you do our poll? We were just going to ask which topics you guys picked and then go and start with the most popular and hopefully work our whole way through things that came up.
And this should be a check all that apply. I just launched it.
Cool, cool. Measuring the impact, medical centers, inclusivity. Still a fight. Oh, a different topic. Gotta vote there. Very cool. All right. We're still getting some answers here. 75% have. All right. So it looks like measuring the impact of RCCs is what was discussed the most. So we'll start there. And then if somebody can remind me to switch topics in a little while, so we can also touch base on medical centers, inclusivity, and I'd love to know what the other topics were as well. All right. So who can, the spokesperson from a room who talked about measuring the impact, what were some of the thoughts you guys had? Now you all did pick a spokesperson in your room, right?
Hi, so Jason from UTMB. We talked about how can we collect data without being intrusive or creating barriers to RCC members. And Jesse and David were able to provide some really interesting insights on how they're collecting data, or they may potentially collect data. But also they were talking about how this data may be shared. And I found it really fascinating as a health services aspiring researcher to see they're duplicating, not duplicating, they're recreating the quality improvement process that has already been created within the hospital systems, and like the stuff that I see in the Institute for Health Improvement trainings and so on. And it's just fascinating to see that it's the same mechanisms. They're trying to find ways to collect comparable data across different organizations. So it was really, and I got to find out what software they were using, which was particularly helpful for me.
Which software?
I believe one was Apricot, and I'm not sure if, Jesse, there was a proprietary software system that they were using in New Jersey or.
Yeah, it's called RDP, Recovery Data Platform. It was made by Faces and Voices of Recovery. Mm-hmm. The whole state, if it's a grant funded state RCO, we use that to collect the data, and Rutgers University kind of uses it and tries to measure the impact through that.
Awesome. And of course, one of the great strengths of RDP is that you guys are using the same outcome measure, the same measures, like for instance, the BARC, a brief assessment of recovery capital. And then it's easy that it's doable to actually compare data from different sites to make a cumulative science, which is super exciting. And I'll also point out for those of you who are not, doing a lot of NIH research, I absolutely agree with the point that you made earlier, Jason, about that NIH is more supportive of building a cumulative science and sharing data, in particular for studies in this field by the HEAL initiative on ending the opioid epidemic. There are very strict guidelines about making data accessible. And I don't mean like you're making personal information identifiable, right? I'm talking about like aggregate data where the identities of people is protected, but the data can be accessible, not just to scientists, but to everybody, to create a platform that makes data usable by the community that, care about these issues. So any kind of work that comes for this, for our initiative here is going to be held up to that standard of being able to be shareable ultimately in the HEAL collective, and increasingly scientists are doing that. So I love that you guys are already ahead, that the recovery community is already ahead of that with RDP and other things. Very cool. What other things on that topic that people talk about in their rooms?
We talked about the actual collecting, how to collect the data. Mm-hmm. The discussion we had was that the data should be collected on a personal level. I mean, you have to make that personal connection. It's all about trust. Mm-hmm. So instead of throwing a bunch of forms in front of them and saying, fill them out, incrementally. And if they ask why, you tell them. The more we know about you, the more services we can get you, the better we can help you. And that's basically what it comes down to. And at least in my situation, a lot of people are more willing to give you that information if it involves helping them. Mm-hmm. So.
And understanding the why of why would I take the time to fill out this information and share all this with you? What purpose does it serve?
Right.
Great.
So
And were there specific suggestions in your room about what you wish people would do better there, in terms of like scientific RCC collaborations, what they need to do better to make that improved?
the time flew out the window.
I know. Mm-hmm.
So we didn't get into it really deeply because there wasn't enough time to do it.
For sure. Anybody in this main room have a thought on that about what you think needs to be done differently? So certainly approach people personally and talk with them about these things, but other things that come to mind in this spirit where you say, I wish people were doing XYZ differently so we can have better interactions.
So one thing that came up in our group is having folks have flexibility in terms of when they want to provide that data. So the use of kiosks, so that they can share the information when they have time, when they're ready to share. And I thought that was a really interesting idea as well. Yeah,
I like that. Greater flexibility. Like one thing we discussed in we're starting a new study, we're talking about breaking it up into smaller chunks. So doing a survey here and getting help with doing that survey, doing like an interview with a staff member at a different time when it's convenient. So it's not just this giant chunk that happens, but that you can pace yourself through it, that sort of thing. If not it works, I'll report back in a year when we've tried it. But that's one of the things we've been discussing. Cool. Other things on this topic?
I think some of the things that I've seen that worked in some research studies is that people actually, rather than just seeing it as an assessment tool that's useful for the people who give the survey, that some people take surveys and they learn something while they do it, or they gain insights from doing them, especially if they do them over time. And I think emphasizing to people that they can use some of the questionnaires that we have like that, where, for example, some people were doing mood tracking or something like that, and they're like, I didn't realize that I was angry so much of the time, and only by filling in the survey regularly did I notice that 80% of the time I felt angry, and I reflected on that. Or that you do like the recovery capital survey and you realize, hey, I'm doing really great on these 5 domains, and oh boy, I'm not doing great on those 4 domains, and then helping people debrief that, so that it's not just we're collecting data on you that we find useful, but that you may get some insight from it that you can use for your own recovery journey and that we can talk about. And so I think that's a really good framing to potentially make people aware of that other people have felt that while taking these surveys.
Great point. And I think the spirit here is interaction, right? Just communication as you're doing these things. Great. Other things that other rooms talked about in terms of measuring the impact. Did anybody have a topic?
Can I jump in, Bettina?
Yes, please.
Thank
Chris.
you. Well, I still hear us like framing this around the individual's recovery capital growth. And I've been really thinking about this for years, actually, is how do we measure the impact to the organization? And I've been gleaning some wisdom from the prevention field and really trying to frame recovery capital or compare it to risk and protective factors at a community level and population-based health and behavioral health equity, but not on the individual level, but on that broader community-based level. And so I'm certainly not there, but that's like, I'm not a researcher, but I've been working with my colleagues around how would we create research aims that get us to that answer, to get us to look at how does a recovery community center impact the community where it's situated beyond those individual measures.
So I think I've been struggling with the same thing. That topic has been on my mind too for a while now. I guess I could challenge us all to think about actually crafting hypothesis. What do you think would be impacted? And then we can figure out about how we would measure that afterwards. But when you think about the community impact of an RCC, what are some of the things you think would happen? What would change for positive or negative, not negative, but positive? What would happen? Anybody have something now they want to share? Also, I'd be super excited to get emails from you guys of any of these kinds of points, because that'll keep me thinking about this topic. And if you tell me your predictions, I'll figure out how you would measure it.
There's a surrogate possibly that might be available in looking at the impact of RCC on the community is some of the work I do in a recovery-informed workplace and assisting employers in establishing recovery-informed workplaces. There's lots of measures to look at, i.e. attendance, behavior, performance, near misses, and significant work outcomes, WCB costs, and general workplace morale. So it's sort of a surrogate. The metrics are much more identifiable in a workplace situation, but it's a good starting place. You know, this is work that my colleagues and I do with employers, sort of as insourcing, and we have a methodology that we assist the workplace in assessing their current workplace, their practices, how to create policy around it, how to review that policy, and what metrics you might look at in order to determine if it's working. So it's a little bit of a microcosm, but I think that what occurs in a workplace is to some degree generalizable to a community. It's a good place to start.
I like it. I like it.
Workplaces are a lot more homogeneous than communities are. The community is a very heterogeneous place, and trying to find metrics that are applicable across communities could be difficult.
Of course, workplace is also easier to reach, right? You can just send an email to everybody on your roster. In a community, that's a little tougher. But I agree, that's a great starting place. Awesome. Thank you, Paul. I might follow up with you later if I can for some more concrete ideas to just kind of keep me thinking that way. And Chris, I'm imagining you were also thinking about the people who weren't even thinking a recovery community center opens near them. They haven't been thinking about this topic, but their life is going to be impacted, hopefully to the better, by the fact that there is now a center in this community. Any ideas for kind of predictions, like what kinds of things would change? Like one of the things I think of is that language, right? The language would change in a community that would more recovery friendly. And that's something that you could track in like Google Trends data, for example, to see what kind of terms people use. What other things do we think would be impacted?
Probably service use in the community, costs related to ED visits, potentially even overdoses with enhanced support from recovery community centers.
Great thoughts. Great
The
thoughts.
education as well. You know, I found recovery community centers partner with schools, other programs, coalitions, and start spreading a message where people become more aware, which helps with lessening stigma.
Very cool. Yeah, great. All right, I'm gonna move us to the next topic because we're out of time. If you have more thoughts, if you could drop me an email, I'd love it. Lily or Lindsay, if you can put my email in here for folks, I would absolutely love getting more thoughts along these lines or any of these lines. Medical centers was also one of the often talked about topics. What were some of the highlights and thoughts and ideas you had in that regard?
For our room, we had such good discussion that we pretty much ran out of time before picking a spokesperson. But I can give a quick summary, and if anyone from my group wants to jump in, feel free, please. But one intervention that someone mentioned, or method of RCCs and medical centers collaborating, was that when folks go to an emergency room in an emergency department, if someone isn't ready for formal treatment, then they can be directed to an RCC, and that they even have recovery coaches who are stationed in hospitals to link people to recovery community centers and other peer supports. And that it's important to identify where people fit in types of recovery in order that so that we can better assist them towards that pathway that will work best for them. And that it's really important to know what resources are in the community so that they can be utilized. Yes.
I think our emphasis was on primarily what I heard was peers with lived experience, in particular, potentially recovery coaches who are accredited and appropriately trained, who are in the medical centers that can link individuals to these services. I heard a lot of comments on peers with lived experience and how it's just going to be necessary in order to ensure that we get people from these medical centers or medical communities into the recovery community.
Great. And I saw here that Carlos mentioned the importance of collaboration, and Brandy shared that they have recovery coaches in the ED. Brandon, if you come from might you share how that came about, who you approached, how you created that collaboration to make that happening? It's okay if you don't.
No, she's speaking, but she's muted.
Okay, very good. I'm sorry.
Oh.
Yeah, I can share a little bit on it. I wasn't actually here when the collaboration started, but we partnered with UC Health and the Colorado Consortium and the Anschutz Foundation, and they conducted a pilot. And we have trained peer recovery coach specialists that are trained specifically for healthcare settings that are placed in the emergency room department. And the study has shown that it's reduced follow-up emergency visits by 39.5%.
Which is very, very impressive. Great. Thank you, Brandy. And Laura, you just shared that Sika, of course, does some of this work, a lot of his work as well. And do you know how that first started? Because it's always tough to start something new. It's certainly easy when you have examples to follow and say, look, it worked here, it worked there. How do you start that conversation?
I'm actually not sure how CCAR is in the emergency department. I found it out because as part of my K99, I'm interviewing emergency department experts. So folks like physicians, nurses, mental health consultants, crisis workers, to develop an app for young adults with substance use problems and suicide risk who use the emergency department. And some of my ED expert interviewees have said, we actually have this great program. So if these folks don't exist in every emergency department, but we already have peer recovery coaches who are embedded within our emergency department. It sounds like they're contracted out from CCAR. So they're not like hired by the emergency department. Instead, they're CCAR employees. There might even be someone who is employed by CCAR who knows better than I do. I've just kind of heard about this program recently.
So I will actually speak on that. I am a CRS who my organization is contracted through our local emergency departments. So when a patient comes into the ER with a drug or alcohol issue, the emergency department will call our local tap line, and the tap line will call us, the CRSs, and we are then we go into the ERs and see the patient and get them into the correct service. That's what we do in Pennsylvania.
That is very
the same
cool.
thing we do in the Springs.
And did you guys?
It's called the warm handoff program.
Right. And how does the ED react to that? Are people at the ED liking it? Are they welcoming? Is this shifting over time? And like, how does it feel?
It's hit or miss. It depends on, the ED and, some doctors and medical professionals kind of snub their nose up at you. But for the most part, we're greatly accepted and appreciated for what we're doing.
That's awesome. And hopefully increasingly so, right? As more studies emerge that show the great impact it has. Very cool.
We also,
all right,
I'm sorry, I apologize.
No, go ahead, Kevin.
Yeah. We also have a recovery coach from Voices at one of the hospitals here as well. And they are actually integrated into the addiction services team. And so they're actually located at the hospital. They stay at the hospital all day. And it's been a great program. And he's actually been very good at linking those participants, those patients to our services here at the RCC. So it's been really good.
Very, very cool. And I am realizing that we are out of time. There's two things that I want to ask. One, I want to say that we had moderators in each room. So our team is going to get together and put together a list of things that was discussed so that we can at least share that afterwards, since we didn't get to hear everything. And I want to ask all of you if we should do this more often, where we actually take time to do these breakout sessions and chat. So if people can give me thumbs up or thumbs down to just kind of see if we should do this again, then we can do that. All right, I see a couple of thumbs. Thumbs. Okay. Okay, cool. I will say this is where we learn. This is how we learn from each other and how we drive things forward. I love this. I really appreciate every one of you guys participating in this and would love to do more of that. So we will put that on our agenda. All right. Then the last thing, Catherine, if you can share the slide to just remind you, we are taking January off because I know it's a busy time of year coming back from the holidays for everybody. The next seminar is going to be in February, where we're going to be presenting the outcomes from our very first pilot study. As you know, this program has funding for pilot studies. The first team is going to be presenting. You heard Sarah earlier today here. She's going to be one of the presenters there, and we are very excited for that. So that's going to happen in February. You can already register, and the next events are going to come up. And of course, we will keep in mind doing more discussions like today. So with that, we can stop screen sharing. I just want to say thank you all for being here. Keep information coming. Do email me with thoughts, directions, ideas. I love the stuff that you've shared, and I hope you have a wonderful holiday season. And I'm looking forward to seeing you all in February.
Will we get notes for this?
Always.
Okay, awesome.
Always.
I also wanted to mention that everything in the chat, we get the chat from these downloaded as well. So, because I know there was a lot of good things in there. So we'll be able to take those and add them to the notes as well.
Yep, they'll send our email.